Ladies and gentlemen, dear colleagues and friends, on behalf of INOS, the International Neurology Society, I would like to welcome to the INOS video educational program entitled Urology in Daily Practice. Why do we address this issue? Well, nowadays, neurology comprises not only the care of spinal cord injured, of myelodysplastic or multiple sclerosis patients. There is a constantly increasing number of elderly patients with LUTs and cerebral diseases, with LUTs and spinal disorders or peripheral neuropathies, and they are referred to the general urologist. Thus, neurology comes into his daily practice. And he must know at least the basic evaluation. And an important part of it is history taking. Therefore, history taking is the first video of this series. History taking is still underestimated. And looking into the guidelines, well, history taking is mentioned, but it's rarely explained in more details. Therefore, INOS would like to close this gap. History taking in these neurological patients comprise not only bladder, but also bowel and sexual function. This is because the neural pathways of these three functions are anatomically in close proximity, maybe even identical. Therefore, history taking of these patients should follow a certain algorithm, as it will be shown on the next chart. We recommend to start with the current urinary symptoms, followed by questions on bowel and sexual function. Thereafter, the history of the neurologic disease should be evaluated. Especially in these elderly patients, evaluation of medications are important, as they may even cause or increase lower tract symptoms. In regards to therapy, the impact of the neurologic disease on the activity of daily living and on dexterity are of great importance. In the following, history taking will be demonstrated in 3 patients with LUTs, but different neurological diseases.
In this video, you will see us interview a 60-year-old man with a C3 spinal cord injury and complaint of nocturnal urinary frequency, a 78-year-old woman with Parkinson's disease and urinary urgency and frequency, and a 71-year-old man with a history of multiple sclerosis and urinary urgency, incontinence, and hesitancy. We will use the 3 patients as previously described to demonstrate different isolated components of our history-taking algorithm. We will not make any conclusions of their pathophysiology based on their history alone, but rather our goal is to highlight the key questions to ask in order to obtain a good neurourology history. Now we are going to interview a patient who has a partial cervical spinal cord lesion. And for the interview, I'm going to have actually one of our fellows, who is a fellow in functional urology, conduct the interview. We begin our interview by focusing on the patient's current urinary symptoms and evaluation of their bladder function. We can divide questions about bladder function into both storage and emptying symptoms, as seen here. In terms of storage symptoms, it is important to assess the presence of urinary urgency, frequency, nocturia, and incontinence. The questions listed here are helpful in elucidating this information.
So how can we help you at your visit here today?
The nocturnal frequency and urgency that I never used to have before.
How many times do you wake up to urinate?
3 times.
Do you think it's the sensation that your bladder is full that wakes you up?
I'm not a real heavy sleeper.
At nighttime, do you ever feel like you'll leak urine if you don't make it to the toilet in time?
No, I don't typically feel like I let it wait that long.
And have you ever been assessed for any history of obstructive sleep apnea?
No.
Have you noticed any swelling in any of your extremities, especially your lower legs in front of your ankles and shins?
It's just been since the injury.
Do you practice a voiding on a schedule?
It pretty much turns out that way.
How many hours do you think you are going between voids?
During the daytime, maybe I could go 3 or 4 hours. And at nighttime, sort of depends, about 2 hours.
Okay. And Did you have that sense of urgency during the daytime where if you didn't make it to your 3 or 4 hours, you felt like you had to go?
I can tell when there's an urgency and go without worrying if I don't get there, I'm going to have an accident.
You may start by asking if your patient experiences an urge to urinate and if the feeling is the same as before their diagnosis or injury. We ask this as patients are often unable to distinguish between the sensation of urge and that of bladder fullness. If the pelvic nerves or the sacral segments are not functioning, the desire to void is absent. However, sensation of bladder fullness is caused by distension of the peritoneum covering the bladder, which is felt even when the bladder afferents are damaged.
Now, earlier you described sensations of urgency. Is this similar or the same to sensation of urgency before your spinal cord injury?
No, that's since the injury.
Similarly, the feeling of urgency or imminence, or that one needs to urinate immediately, also relies on proprioception of the pelvic musculature conducted by the pelvic and pudendal nerves. Therefore, you should ask if they have a feeling or sensation that they are about to urinate, and if that sensation differs from that which was present before their diagnosis. When assessing emptying symptoms, one must inquire how urination is initiated by the patient and if they use physical maneuvers to initiate flow. A decreased force of stream may be due to many causes, including obstruction, detrusor sphincter dysynergia, or poor bladder contractility.
When you urinate, do you feel like you have to strain to start your stream?
Like generally not so much to start, but to maintain.
So it sounds like you might bear down to help empty your bladder.
Yeah, at times I do.
Do you ever press on your belly to help empty? Do you often sit and wait after you think you finish urinating to see if any more comes out?
I do.
Have you noticed if your bladder is full, you recognize any abnormal sensations such as a headache, sweating, or flushing?
No, nothing like that.
We ask these questions to determine if the patient has any signs of autonomic dysreflexia. Patients with a spinal cord injury at T6 or above may respond to a stimulus such as a bladder or bowel distension with a profound unopposed sympathetic outflow, resulting in hypertension, reflexive bradycardia, diaphoresis, facial flushing, altered mental status, and or headache.
It's my understanding that the voiding symptoms at night are your biggest complaint. Were you able to fill out the voiding diary before you came in?
Yeah, I did do that for a few days.
A voiding diary is a helpful tool to objectively capture a patient's fluid intake and urine output over a 3-day course. This is more accurate, often, than their own personal recall. Here you can see a representation of our patient's voiding diary. Notably, the patient does not have nocturnal polyuria, which is defined as greater than 1/3 of the total urine production overnight. Next, we'll focus on assessing the patient's bowel function. Similar to the assessment of bladder function, when we ask patient about their bowels, we ask about sensation and symptoms. Again, you want to ask if their sensation differs from before their injury or diagnosis. The ability to sense the passage of stool or gas through the rectum depends on the rectal autonomic nerve supply and on the pudendal nerves, which conduct proprioception of the rectal sphincter. Frequency of bowels is also a key factor, and the presence of constipation or fecal incontinence should be queried. Constipation may contribute to obstructive symptoms or urinary retention, and both may predispose to infection.
Do you have any problems with constipation?
I do at times. I use Colace. It's still a pretty formed stool, but yeah, that doesn't change.
So when you're having a bowel movement, can you actually sense the feces passing through when you have the bowel movement?
Yeah, I can feel that pressure.
And if you pass gas, do you also feel that sensation as you pass gas?
Yeah.
We now turn our attention to assessing the patient's sexual function. Sexual dysfunction is common among men and women with neurologic conditions. Men may suffer from neurogenic erectile dysfunction and or ejaculatory problems. Erections may be absent or, if present, only be achieved either psychogenically or reflexively. It is important to note that ejaculation is a reflex composed of emission via sympathetic hypogastric nerves, followed by expulsion via contractions of the bulbar cavernosus via somatic pudendal nerves. Asking about the force of ejaculation can also give clues to the extent of the patient's nervous injury. More detail about female sexual function questions will be addressed a little later.
So have you noticed any change in your ability to become aroused or in your libido since your injury?
Not really with the libido, but the response is definitely different.
Are you still able to maintain or obtain an erection?
Yeah, sometimes I think I get maybe 70 to 80% of what I would have done before.
Is that erection sustainable for intercourse?
Barely.
And are you able to achieve orgasm?
Yeah.
And are you able to ejaculate?
Yeah.
When you do ejaculate, is it a similar force as prior to your injury, or do you find it's more of a dribble?
A lot less force.
As this chart illustrates, many medications commonly prescribed for adults have significant effects on urinary function. Thorough evaluation of a patient's current medications may offer insight to potentially overlooked factors contributing to their urinary complaints. Our patient is on tamsulosin for his urinary stream and an H2 blocker for his reflux. It is important to note that this antihistamine medication has been associated with urinary retention, and alternative medications should be sought if possible. In summary, this patient is a 60-year-old man with an incomplete spinal cord injury whose chief complaint is nocturia with urgency. He may need further office-based testing to see if his complaints are related to his neurologic condition or to obstructive uropathy. We are now going to interview our second patient, who is a 78-year-old woman diagnosed with Parkinson's disease and with complaints of urinary urgency. Our focus in this abridged portion of her interview will be to understand the patient's bladder and sexual function and a review of her medications. What brings you into our office today? What's going on?
When I go, I felt like I wasn't emptying completely.
So you mentioned you were having some issues with the bladder.
Yeah,
How long has that been going on for?
it's only been a few months.
When you feel you have to go, do you have to get there right away?
Sometimes, not always, but sometimes I have to. Now I gotta go.
And do you ever have to get there and you can't make it and it starts to come out on
Yes.
its own?
Yes,
How often does that happen?
maybe once or twice a week.
Okay.
Maybe twice a week.
And do you have to wear any pads for
Yes.
this? All right. Are you bothered by getting up at night?
No, if I have to go, I have to go.
I see you did a bladder diary. Here we can see a representation of our patient's 3-day voiding diary. She voided 7 times per day, had 1 episode of nocturia, and had 3 episodes of incontinence throughout the day. Behavioral modification may not be helpful in this patient since she does not have an excessive fluid intake and her voids are less than 8 per day. The key aspects of sexual function for the female patient differ from that of a male patient. While some of her function may be dependent on whether she is neurologically intact, some function may also depend on portions of her gynecologic history. It is therefore helpful to ask about pregnancies and deliveries, if she has had a hysterectomy, and about previous pelvic surgeries. In addition, we ask the patient if she is sexually active and if she has any discomfort with vaginal intercourse. Previous surgical history, menopausal status, and neurological history may all contribute to pelvic floor dysfunction. Do you have any children?
Yes,
Okay, how many pregnancies did you have?
4,
And were they delivered vaginally or C-section?
gradually.
Have you had a hysterectomy?
No,
Are you sexually active?
yes,
Do you have any pain?
not
or?
at all.
Okay. Are you able to have an orgasm?
Yes,
Okay. All right. And is that during intercourse or with stimulation or?
during intercourse.
Many patients with Parkinson's disease are prescribed medications which can affect their urinary function, and it is important to review this aspect of their history. Some medications have anticholinergic effects, which may impact bladder emptying. Currently, with whatever we've done and the oxybutynin, if we're looking just today, how's your bladder functioning?
I think fine.
Okay, so essentially what we have here is a very highly functioning young woman with Parkinson's for about the last 15 or 16 years, whose primary complaint had been urgency and urge incontinence, using diapers, and also some trouble with flow, of the sense that she wasn't able to empty completely and get it all out. However, with the use of oxybutynin in this particular patient, that seems to have controlled this problem significantly. So overall, she's actually done remarkably well with relatively conservative management of her overactive bladder type symptoms in this neurologic setting. Our final patient is a 71-year-old man with a 25-year history of multiple sclerosis. He complains of urinary urgency incontinence, and issues with mobility. In this interview, you will see him explain how his mobility limitations impact his bladder control and affect his quality of life.
In terms of your bladder control, what's your main complaint with your bladder?
When I go to the bathroom, it's not a matter of just going to the bathroom. Because I have MS and I'm by myself, I have no balance. It takes me 20 minutes, so that's a problem.
In summary, we have highlighted some of the key questions necessary to take a focused neuro-urologic history. Further evaluation, including a physical exam and office-based testing, is necessary for all of these patients.
Dear colleagues and friends, I hope you enjoyed this video. And at the end, I would like to thank Access to Healthcare Coloplast's partnership program for having supported this educational video.